Hello everyone, and good afternoon, good evening Europe, good morning US. We are here for the 15th episode of Vascupedia Views, Vascular Interactive Episodic Web Symposium. And today we have the great honor and pleasure to have our friend August Isa from Bilbao in España, and he will talk to us about pedal plantar loop revascularization tips and tricks. We know August is a very skilled surgeon from Spain, but he's also a very wise doctor, and he will guide us through the tips and tricks of the revascularizations, but also the pitfalls and the possible consequences of a technique which is not completely performed in the correct way or in the correct patient. So, August, the microphone is yours, and please entertain us with your fantastic presentation. Thank you.
So thank you very much, Lorenzo, for your kind introduction and from your friendship. So these are my disclosures for this talk today. If we talk about the plantar loop technique, we definitely need to pay tribute to the Incredibile Squadra Italiana, because this gentleman not only invented the technique more or less 15 years ago, but also, among others, have contributed to spread the word over the entire world. And as Marco Manzi nicely mentioned in chapter 3 of Vascupedia, it is essential to be familiar with the anatomy, because otherwise you won't be able to fill the gaps when you're dealing with complex arches. So it is crucial to know the anatomical variants of the BTK arteries, the anatomies of the foot arteries and its variants, and the connections from the anterior and the posterior circulation. And it's also crucial to perform the two orthogonal views, the lateral one and the AP view, because this is the only way to have a real 3D idea of what's going on, because what it may seem one thing in one view can be the opposite one in the contralateral view. So just let me show you one example. This is a case we performed of a plantar loop which went quite easily, but when we performed the AP view, surprise, surprise, we realized that we have undergone transcollateral from the DP to the medial plantar artery. So I'm going to hand over to you, Lorenzo, for the first poll.
So the first poll, and I want you to remember to exit from the full view screen and to be able to answer the question and to see on your screen. So the first question for August for you is, what is your most used bailout strategy in case of BTK antegrade recanalization failure? So option number A is surgical rescue. Option number B is retrograde puncture. Option number C is transcollateral approach. And option number D is plantar loop technique. So please answer to the question. And at the end of a presentation, we're going to comment the result of the poll with August. So August, please continue. Thank you.
Okay, so due to the specific features of plantar arteries, this procedure is not always a straightforward maneuver, and it's due because they are quite small and tortuous vessels with numerous collaterals arising from them. There's a quite typical calcium pattern, which is the medial artery calcification, and as Lorenzo always mentioned, this is related with a rough intima, which is prone to be dissected. And what are the complications of these plantar arch arteries? Number one is a spasm. They are quite spasmodic arteries. You can also get microembolization following your angioplasty, a section, as mentioned. You can have a perforation due to tortuosity, lift plaque, or even complete arch thrombosis. And if we talk about the plantar loop maneuver, we definitely need to distinguish two different scenarios. If you use the plantar arch as a pathway in order to bidirectional recanalize an opposite vessel, or if you use the plantar arch as a target itself in order to increase forefoot perfusion. And if you use the plantar arch as a pathway, my first step would be to choose the right pathway, because you want to transit in a nice, smooth, and easy highway rather than to get entrapped in a complex hash, sort of nightmare. And if you get entrapped in this situation, I would definitely consider an easier alternative access, such as a retrograde access, even a double retrograde access, or a transcollateral approach. And when do we use a plantar arch as a pathway? I'd say that the indications are more or less the same of a retrograde puncture when you're trying to perform an opposite recanalization procedure and you don't have a proximal stem, or you are unable to cross anterogradely, or get entrapped in a perforation, or you cannot re-enter following a subintimal dissection. And there's also a quite common indication shown in the bottom right of the screen, which are heel or planted wounds that cannot be approached anterogradely with complex retrograde bailouts. And if you want to use the plantar arch as a target itself to increase perfusion, I would not use this maneuver in case of limited ulcers affecting just one angiosome, because they can just be easily dealt with inline flow with single vessel inline flow. And of course, if you're planning to schedule a Lisfranc or Chopin amputation, I would also don't recommend to recanalize the arch, because this can be easily damaged with the amputation maneuver. It's quite pointless to do it. And definitely, in my opinion, a real distribution failure as such is not an indication for a plantar arch recanalization. And in order to describe the different angiographic patterns of the plantar arch, Kawahara described in 2012 his classification being type 1, a complex arch, a type 2, an incomplete arch, being type 2A, the absence of the plantar system, and type 2B, the absence of the dorsal system. And finally, a type 3 is the absence, angiographically absence of the plantar arch. But behind a type 3 arch, you can find different scenarios with quite different prognosis. And that's why we think that it could be interesting to slightly extend Kawahara's classification. So a type 3A, an angiographically occluded arch, can be an arch in which you don't have a complete occlusion with patchy patent areas, hibernated areas with collaterals arising from them. So when you perform a plantar arch recanalization, not only obtain flow into the arch, but also in these patchy areas, and therefore increasing forefoot perfusion. A different scenario is a type 3V arch in which you have a SAT, an absence of runoff, or a real complete occlusion of the arch. Because for me, this is quite pointless to perform a recanalization of the arch, because you will end up having flow into the arch, but in a roundabout situation without increasing the forefoot perfusion. And finally, you have a 3C arch, which is the absence of arch due to an anatomical variant. And this seems to happen in up to 10% of the cases. And as you can see on the screen, this is not the sort of procedure that you can see, you do one and you teach one, because even Lanfroy Gracciani, who is the inventor of the technique and performs it 20% on his cases, has reported up to 30 to 40% failure rate in his plantar arch recanalizations. So back to you, Lorenzo, for the second poll.
Second poll. So guys, again, leave the full screen mode and come out from that to see the second question from August. So please, August, show the question. The question number 2 is about what is your most used indication for the plantar loop technique? Answer number A, never use it. Answer number B, type 1 plantar arch. Answer number C, type 2 plantar arch. And answer number D, type 3 plantar arch, with all the different classification that August has explained to us. So please vote, let us know what you think, and let's discuss the results at the end of the presentation. August, the microphone is yours again.
Thank you. So from the practical point of view, this is my toolbox. We routinely use a short antegrade sheet for our BDG cases, but when we are planning to perform a complex case, we switch to a 6 French or even a 7 French antegrade sheet up to the popliteal segment, and we put a perfusion of verapamil, hepsaline, and nitro in order to avoid clotting of the sheath. And we use this long sheet because it permits to perform selective angio, dual wiring maneuvers, or any sort of bailout. Thereafter, we use a long catheter, a Western 2 4-French catheter, up to the ankle in a coaxial way, and this increases your pushability to treat these BDK or BTA vessels. And you can also even upgrade this system in a 3-axial system if you put a support catheter inside the Western 2 catheter. And as you can see, we use a low-profile platform, 014, and we use really hydrophilic, soft tip, high trackability wires like the Regalia XS. And believe me, you cannot imagine to perform this sort of loopy thing coming from the peroneal, transcollateral, or plantar loop without this sort of wires. And if you want to be more accurate, you can even taper the tip of the wire with a Fielder XT 0.9 on the tip. And if you need support, what we do is switch to a common ES, which is our workhorse for BDK cases, and we seldom use CTO wires because they're quite prone to perforate the vessels due to tortuosity. So if we talk about wiring strategies, we perform what we call a dynamic recanalization. And what does it mean? Well, we basically alternate the projections, the X-ray views, continuously to have this 3D idea of what's going on. And we also perform super selective angiograms to reveal these mentioned hibernated vessels and to predict what is the right track for our wire. We shape the wire in a conventional way, 1 or 2 millimeters to the tip, 45 degrees. And if we want to engage the ostium, we perform a double curve in sort of Judkins Wright-like shape. If the vessel is patent, we gently slide the wire. And if we end up in an occlusion or a high stenosis, we drill our wire. But never, ever push your wire because these sort of vessels can be easily dissected. And as we mentioned, we use a non-traumatic comforting wire for navigation. And in case of occlusion and need some support, we switch to a common ES, like 3-gram tips. The last point is a key point, take home message. Try always in the arch to stay intraluminal because this is a quiet terminal circulation. And if you end up in a dissection, this can become a complete disaster. So let me show you an example of a type 2A recanalization arch. So we put our wire, get into the first metatarsal, get back. So engage the ostium, slide the wire up to the occlusion. We switch the projections to see what's going on with the wire, cannot get through. And then we will need the support catheter and surprise, the arch was not actually occluded. This is a hibernated arch. And then we drill again our wire up to the point in which we could pass to the metatarsal, change again the projection to the lateral view, retrieve the wire, and we finally could make it. And as you have seen, it's really important to have a good support catheter to increase the pushability, the penetration power of your wire. And for me, the perfect match is the Regalia and the Corsair catheter from Asahi, because this support catheter has a unique feature of being able to progress 90 degrees bends without prolapsing the wire. And this is quite important in these sort of tortuous vessels. So once we have the wire there, we pre-dilate the stenosis or the occlusion with an ultra low profile balloon catheter, the Armada XT from our single mark. And then we perform the final dilation with long balloon catheters to 2.5 millimeters. In case of recoiling or residual stenosis, what we do is to use short, non-compliant balloon catheters. And now you have actually available amazing balloons like the jet balloons that can be inflated up to 22 atmospheres. With regards to complications, we have already mentioned, number one is spasm. And the basic way to prevent spasm is to be extremely gentle and to use low profile platforms. And if you got a spasm, what we do is to put a bolus of 200 microns of nitrous. Some physicians prefer verapamil or even papaveri. And a good tip as well is try not to overdilate the vessel. So we use low pressures, 4-6 atmospheres with long inflation times, 3-5 millimeters or even more than 5. it's really important to be meticulous. And as Roberto Ferraresi always mentioned, don't dilate or treat what is working reasonably well, because what can feel tempted to treat this arch following the usage of the arch as a pathway to treat an opposite vessel. But when you feel tempted to do that, always think that you can end up having a thrombosis of the arch, dissection, or microembolization. And if you use the arch as a pathway, try to perform your angioplasty from the antegrade wire in order to avoid passage of used lump balloons through the arch to avoid a spasm or any injury. You also need to be cautious when you exchange your wire from your support catheter, because the support catheter can get entrapped into the arch or kink, and if so, I would recommend just to retrieve half an inch gently and use a hydrophilic wire. This is important, hydrophilic wire, to get through it. And finally, as much as possible, try to retrieve your wire over a catheter to avoid the shearing effect of the wire on the arch. For me, this is the key point, the most important message of our presentation. Don't extend your dissection into the arch, because you will end up stripping the runoff branches, and you will get these nice, fancy, and sexy pictures to show you to your colleagues, but completely useless. Believe me, completely useless. It's what we call the useless perfect C. And if you get entrapped in such situation, you need to look for the back door. So you will need to perform a retrograde puncture of any digital artery or the plantar arch itself. Also, it's important to keep away from the SAD, because in my opinion, plantar arch revascularization would not be indicated in a real failure of the distal distribution system. For this, you need to perform a DVA or percutaneous DVA. And as mentioned, try to keep away from the iatrogenic SAD. Don't extend your dissection into the arch if you don't master the bailout maneuvers. So finally, with regards with the completion angio, you need to be patient, because you don't always get this nice and fancy image at the first attempt due to the spasm effect. And for that, we perform what we call the dual injection. We learned that from Fadi and Jihad Mustafa from Michigan. We use the support catheter and the sheath to assess that the loop is intact, that you have brisk flow with preserved runoff collaterals, and to weigh up the role of competitive flow. Back to you, Lorenzo. Last question.
Last question. The third one is about on which of the following theories do you base your recanalization strategy? A, single straight line flow to the foot. B, as many vessels as possible to the foot. C, inline flow to the affected angiosome. Or D, angiographosome, blastosome, woundosome, as you want to call it. So I think it's a very nice question, and also it's nice then to correlate this kind of strategy then with the type of patient, so also the type of tissue loss and the extension of tissue loss that the patient presents. We're going to discuss this and the other parts at the end of the presentation. Now, August, again, please continue.
Okay, thank you so much. And as Lorenzo mentioned in chapter 1 of Vascupedia Views, there's quite a contradicting data in the body of the literature with regards to direct versus indirect revascularization and the role of the plantar arch. Most of the studies are retrospective with scanty prospective data. We also learned from the Japanese registry, the rendezvous, that plantar arch revascularization is related with improved healing rates and lower healing times, but this is still quite a lot of unsolved questions. I would say that we all agree that if you have a complete arch, angiosome-directed angioplasty seems not to be crucial for limb salvage. With a partial or absent arch, direct angiosomal PDA seems to be superior compared with indirect angiosomal PDA. But if you cannot perform a direct angiosomal PDA, it seems that reconstruction of the plantar arch is a better strategy compared with multi-vessel recanalization. But nevertheless, further studies are needed to identify which sort of patients may benefit from arch reconstruction. So in conclusion, pedal arch can be performed safely and should be considered in appropriate clinical situations. It's really important to be familiar with the anatomy to achieve a nice procedural success. You definitely need to be meticulous, and be familiar with the devices, because what is a quite nice and elegant maneuver can become a disaster in case of failure. And don't touch what is nicely worked. If needed, consider other potential easier alternative approaches. So that's all. You can just reach me in my email account or any social media. Thank you so much.
Thank you so much, August. It was a fantastic presentation, also with a bit of caution also at the end. Of course, as you said, sometimes the images and the procedure can be sexy, but the result is not. And that's why I always, when I try to do my things, I always try to put videos and not images, because for two reasons. First of all, with a video you can see the flow going down to the toes, and also with the flow you can also see sometimes it's not perfect, because also there's a competitive flow when you open both arteries, and so you will never see this kind of perfect plantar loop with the C. You will see the vessels coming together, even competing. So very nice presentation. So thanks again, and we're gonna see now the results of the polls. The first poll was what is your most used bailout strategy in case of PTK antegrade recanalization failure? And this could mean the perforation, not possibility to advance the wire, or any kind probably also of subintimal dissection at the level of the ankle. So when it's better for me to stop and to try something else. So people said 10% surgical rescue, which could be probably done in a second stage. Retrograde puncture, 80%. Is also my, if I voted, I didn't, but if I voted, I would choose retrograde puncture. And transcollateral approach, 10%. Personally, I never done a transcollateral approach. I feel like it's very risky. I always prefer to go retrograde, but August, please comment on this poll.
I definitely agree with the outcomes of the poll. To be honest, I'm more pedalist than looper. I think you definitely need to switch to a retrograde puncture as soon as possible. It has been reported rates like 15-20% bailouts, but to be honest, in our experience, we perform it like in 40-50% of the cases. We have slightly changed our strategy because we are now trying to avoid the dissection, because bailouts for dissection in BTK are not really amazing. So we could not just go through intraluminal, and typically we immediately switch to a retrograde approach.
I think it's a very important point. I want you to talk to us a bit more about your let's say you're more confident now doing this. So I think it's a very important thing is that not only the surgeon, most of the team needs to be more confident. And the more you do, the more the team is ready, and the more you, as monkeys, the more you practice, the better you are. Am I right?
Yeah, definitely. This is teamwork, and you just need to have all of the team involved, because most time in this last option, guys, you put a lot of pressure on your shoulders, and if you don't have your team involved supporting you, or even stepping you on the ground and just switching for plan B or whatever, it's messy. So you definitely just need to have everybody there focused on the procedure. Yeah.
Perfect. And also I would like you to comment on this safety, because sometimes people, especially in UK, they say, oh, the retrograde access is not safe. But do you think it's more safe to go retrograde puncturing a potential landing zone for a bypass in a sheetless way with just a CXI, or to dissect the artery antegrade into the dorsalis pedis and risking to lose all the branches of the foot arch? What do you think is the correct answer?
No, well, you know my answer. Well, the thing is, you have a look to the complication rates of a retrograde puncture, they are lower than 1-3%. So it's quite unusual to have a thrombosis or a real complication that threaten the landing zone for a bypass.
Great. Yeah, there was a nice meta-analysis from Schmidt, which came out, I think, in 2018 or 2019, which takes all the studies together, retrograde puncture at the level of the BTK vessels, and actually, as you said, the rate of complication is very low. So sometimes I have to fight a little bit on that, but I'm happy that at least from Spain you are on my side. Okay, so the other poll is what is your most used indication for the plantar loop technique? And never use it is 30%, and I'm happy that also we have 1/3 of the people which joined us, because that means that they are interested in developing something new. Type 1 plantar arch is most of the people. A type 2 plantar arch, it's roughly 8%. Your comments on that?
I think it's quite normal. It's really tough to recanalize an occluded or highly diseased arch. So most people usually likes to transit it what we have called the highway. I would think about, if you don't want to touch what is nicely working, you can also perform a bilateral retrograde puncture, even in that case. But I think it's wise just to use the arch in a nice way without getting trapped in real issues.
I think it was very nice also to present during your presentation about the possibility of having hibernated vessels. I think it's something that people sometimes don't think about. There's a small occlusion, then you cross this, and then you see all the metatarsal arches.
Yeah.
It's like a dream, isn't it?
Yeah, or the whole arch itself. So you always mention, I really completely agree with you, you always need to treat it. Don't say this is a no option without at least one or two attempts. At least one.
Great. Yeah, definitely. And also I've seen some cases where you puncture antegrade, the dorsalis pedis, or even the posterior tibial to recanalize the arch. Would you tell us more about this technique? How many times you do? How much is successful?
No, I don't actually have huge experience, and this is a sort of bailout you perform once or twice in your life, because you really get in trap and you just need to do whatever. But I would not recommend to do that at home.
Don't do that at all. Disclaimer. Okay, great. Thank you. Because sometimes, we are amazed by the cases of people like you, but also we need to keep in mind that not everyone, step by step, as you said before, step by step. And I'm glad that people with 30% of the users today are people who never did a foot plantar arch recanalization. That means it's going to be a good start. And I think you presented very well also the possible pitfalls. The third poll is about on which of the following theories do you base your recanalization strategy? And then it says very different pattern of answers. So some people, it's a minority, says that single straight line flow to the foot. Then after that comes as many vessels as possible to the foot, which is a very enthusiastic and young probably answer. Then together with this, there's inline flow to the affected angiosome and angiographosome, blushosome, or what I call the woundosome. So I think it's nice to comment on that. What would you say? What's your approach?
I definitely go for the blushosome. I like blushosome. The angiographosome from John Rothbard sounds quite odd to me. But the thing is, as you always, we have talked about that, angiosome is not really, for me, a good theory in this sort of disease vessels with new collaterals that have just been built up along the life of the patient. So most of the lesions are 2 or 3 angiosomes involved on the lesion. So I think you need to look for the blushosome, the vessel that is feeding the injury, and then go for it. Yeah,
I think it's a very wise comment. Also because this kind of eternal debate, angiosome not angiosome. I think this the blushosome, woundosome, angiographosome really finishes the debate, because this is where you want to have. I mean, especially in Rutherford 5, and I think that most of the patients we treat are Rutherford 5. I think there are few patients compared to Rutherford 5 or Rutherford 6. Am I right? So, and Rutherford 6, maybe as many vessels as possible could be an answer. But when you talk about single ulcers, I think we are confident say that the blushosome could be the answer. So, and another thing I wanted to ask you is do you usually because it's something that's very important also for the juniors, for the people who follow us. Do you always perform the anteroposterior view of the foot when you do a BTK recanalization? Yes or no?
Definitely. That's essential to see what's going on. If you lose the vessel by the end of the procedure and you need to perform a rescue, if you don't perform your angios, the 2 projections beforehand, you will never know what has happened.
Great. So now you, young guy who are following us, remember that you need to do anteroposterior view of the foot always, because I see, and also it's very nice that you presented recanalization, like it's very nice to do. So with the two projections, so you go, you move, you move, you move. You are very dynamic. You have to be a patient radiographer, but this is the only way not to end up in a potential disaster. So I'm gonna put a question. It's coming from Kumar from Chicago, and he's asking, any cocktail given through radial access?
To be honest, I know you guys there at the States use quite a lot for the TAMI procedures, but in our case, we just put some hep saline in the retrograde axis because, in fact, we usually go sheetless, so we don't use anything there.
So usually use the retrograde axis to recanalize the vessel, and to recanalize the vessel, then you snare the wire out, you remove the axis straight away. Am I right?
Yep.
Okay, and we want to talk to us a bit more about the cocktail that you give, because I've seen that you have given an infusion. So what you put? You put in a 1 liter saline bag. What do you put? Yeah,
we put 2.5 milligrams of verapamil, 400 or 200 micros of nitro, and 50 milligrams of hep saline.
Hep saline, okay. And if you think it's this is like a continuous infusion, am I right?
Yeah, but in a low rate, just drop by drop, because I don't want to overload our patients that are quite bad heart, and that's why it's not massive.
It's a very dangerous game also for the patient with dialysis, I think, because it's you know, the fluid overload could be a proper issue. And when you put the 5 French sheath, the 6 French sheath, you said even 7. Do you do it like, do you put the 7 French when you think you want to do kissing balloons, or how do you choose the size of your sheath?
Yeah, that's all. Well, we basically use the 6 French, but if you want to perform some kissing stents or even a atherectomy or a bailout, more complex with 2 catheters, support catheters, you need more room, and probably 6 French is not enough. You can just put in a 6 French 1 catheter and a wire, but not 2 catheters. So then it can be wise just to upgrade and then just feel more comfortable to perform the whole thing.
No, because I mean, I feel like if you don't upsize also the sheath at the right moment, then when you have 2 wires, 2 or 14 wires, then you're gonna be stuck.
You get in trouble.
You can't do it. Yeah. And when you do the foot arch, so you said you're using 2 different 14 wires. So you use the regalia and then the command. Does it happen to use the same wire for both, or do you really like to change it during the recanalization? Because, for example, I use the command 14 quite often to recanalize the foot arch when I do.
You're right. Well, I think if you
have experience with that wire that you mentioned.
Well, with the command, if both the command ES or the standard command, you can perform most of your plantar loop maneuvers if you have a nice vessel. But the more tortuous the vessel gets, the more difficult to navigate. You know, the steering the wire is not that easy. So you need the sort of hydrophilic soft tip like the regalia that it just can engage wherever. That's why.
Because it's also nice that you mentioned the Corsair, the catheter from Asai. Is it the one with the silver tip? Am I right?
Yeah.
Okay, so can you tell us more also, because I mean, I think one of the errors that people can do is like to try to use an 018 CXI, for example, with an 014 wire. I think in the foot arch I had once this complication, so I remember I was quite junior at that, and I did dissect because, you know, just the profile between the 014 wire and the 018 catheter was not ideal. So
yeah, well, the thing is, it all depends on the sort of arch do you have. If you have a nice arch, I usually use the CXI 018 with my 014 wire. But if you have a disease arch, it happens what you have mentioned. You can just get trapped there or dissect or even cause a perforation. So if you're dealing with a normal arch, more or less everything can run. But if you just complicate your case, the more you complicate your case, the more specific devices you need to use.
Okay, so for some reason I can't put up the questions, but I have a question for you. It's about the foot surgery with the the plantar arch? Because you mentioned this kind of amputation, of course, which is quite short, the short part, and you said there's no reason to recanalize the plantar arch in these occasions. But my question is, do you usually work with the surgeons, the foot surgeons, to try to do an amputation, especially a transmetatarsal, to save the foot arch? Do you perform an angio before the amputation? Do you mark on the skin in some way? How do you do? Because I know different approaches. I would like to know yours.
Yeah, well, the thing is, I'm a vascular surgeon. So we perform our amputation ourselves. We don't have foot surgeons in Spain. So we perform the revascularization, and then based on the outcomes, we perform a tailor amputation.
Okay, so do you look at the angio? So you do it at the same stage. So one stage, and then you carefully look at that.
It depends. Ideally, I would wait for a couple of days just to give time to the flow to look for to recanalize, to revascularize the whole tissue, which is a watershed tissue. But sometimes, yeah, you need to perform it in case of you have abscess or any sort of wet and green or.
Okay, and because it's important also to know if you, for example, you perform the amputation 2 days later, do you use any marker for your foot arch, or do you directly go, with an angio, or you don't do anything, for example?
No, actually, since most of the cases have been performed by yourself, you have in mind what was there, and then based on that, this is you perform your amputation.
Okay, so you perform it based on that. Of course, if it's especially if you are the same operator, it's easier than to leave someone else doing. And I think this solves. Of course, maybe you don't.
Yeah, you were already there, so you remember.
You remember very well. You remember the patient remembers you. So it's important. And also another thing, like, do you always use 014 wires in the foot arch, or do you also sometimes use the 014 wire? 014 or 018? Always 014, because I think it's quite. I've seen people doing with an 018, but I personally think it's a bit unsafe, isn't it?
Yeah, you're right. I've seen people doing with 014 platform, but I don't really like them. It's quite spasmodic, and you can just easily get the vessel injury. Yeah, I don't like it.
And for the plantar loop, do you sometimes puncture the lateral plantar artery? So as a bailout, so the distal punctures. What do you do when you puncture a vessel which is distal, like you showed us the metatarsal artery? So you puncture and you give, for example, some cocktail before to prevent the spasm, or after you pass the wire. How do you do?
Well, we puncture the vessel, then we pass the wire, and then we put some nitro there. Yeah. And sometimes this is not usually the sort of like first attempt success. When you make your first puncture, if you fail, we automatically just put some nitro there, just trying to avoid a spasm. Yeah.
Okay, so now I can see other questions. So one is coming from Sensebat Ozgun. Education and fellowship. How do you implement these difficult techniques in your fellowship procedure? Thank you for this great session.
I think probably in terms of educational, at least in my country, we need just to educate senior staff, because this is not really hugely implemented techniques. So I think we are far from these high complicated cases to be implemented in terms of education for fellowships. Yeah.
And my question is, I know that both of us do workshops. How much do you believe in these workshops with people coming for 2 days? And how much do you think they get back home? And for me, like, it's more like I'm very happy to have the people sometimes around, because I learn from them and instead of teaching them. But it's a sort of a sharing, and it's so nice for me. I don't know. Is it the same feeling for you?
Yeah, definitely. I think it's in both ways. You learn quite a lot from them, and it's amazing when they just send back you any picture when they get back home and achieve a puncture or whatever. This is amazing. This is really nice.
And how much do you think that the companies needs to be involved in this kind of education? Because this education is also difficult to obtain, maybe during, as Sensebat said, during your fellowship. So how much do you think companies should be involved in this?
100%, because without the support of the companies, the economical support you cannot just try to organize this sort of stuff or any workshop or whatever. It's quite difficult to move people from one country to the another and to organize a session in a daily practice of a department. Yeah.
Yeah. Okay, great. So another question is coming from, oh, sorry, no, it's the old one, from, wait a second. B. Javier. What success rate of plantar arch recanalization are you satisfied with?
Good question. Good question. Javier is a friend of mine, which is not really a friendly question, I would say. Where I would say people has mentioned even revascularization like 60%. It's amazing to see that people from Japan in the rendezvous trial reported like 85% success rate, but they are the top guns, people like Urosawa, Nakama. I would say 60% is fair enough.
Okay. And also, you know, I will try to make a question even more difficult. In how many cases of your BTK cases, is the plantar arch revascularization necessary?
I would not say that this should be a target at the beginning of a procedure. I think if you just get a good outcome with a blast sum accomplished, I would not get in trap, look for issues. If you are in a last option, definitely you need to do it, but not just try if things will go or not.
Good. And also another question is about your experience with DVA. So how many patients do you think that are no option in your very skilled hands? How many patients on, let's say, Ratifor 5 and 6 are in need of deep vein arterialization?
I would say that not that much. It has been reported to be like between 15 to 20% of the cases, but as more distal you go, more selective with your angio, more skilled you are in your revascularization, there are not that many patients there on this non-option category. Probably now we are seeing quite a lot of them in from another point of view, because there's the SAT concept, which is just being established. It's a real issue. You can just have your vessel, but if you don't have a runoff, it doesn't make any difference. You can recanalize your eyes, have a nice picture, but if you don't have a runoff, you definitely need to go for a DVA. But in terms of patency of vessels, not that much.
Great. And how much do you use ultrasound in your practice? So we have seen people, especially from US, like Jill Somerset, for example, that uses the ultrasound for everything, and you know they manage to understand the flow. And I think that's actually, I've seen also myself that sometimes with ultrasound you can see things that you don't see with angio. Is it your experience too? How much do you use ultrasound?
No, not really. I'm not really skilled on ultrasound management. I'm far from Jill, which is amazing. The PAT concept is huge. I love it. And to be honest, even in my OR, we don't have a nice ultrasound device. We don't have a J-stick approved. So no, we basically perform our cases with X-ray or angio.
Okay, because this is a nice point. Hopefully Mustafa is not listening to this presentation.
Yeah.
No, but it's important also to know the different approaches, because it's important that everyone masters whatever he feels comfortable with. And but I think that sometimes, especially with this kind of extreme puncture, the ultrasound is not as accurate at the fluoro, because you need to have two hands. And essentially, I mean, this is my small experience. When you do like puncture very small vessels, one hand needs to be on the foot to keep it straight.
Yeah, it's quite messy, yeah.
So yeah, I don't know. Apart from Shiva and some other Indian gods, probably there's no one else who can have 3 hands or 4 hands to do. So I think it's important to have one hand free to all the foot, and like also metatarsal arteries and stuff. It's very small, and a small movement of the foot. And also another question is, do you usually perform your procedures under local anesthesia or general anesthesia? This kind of extreme.
No, general anesthesia, because since we perform our puncture on the road mapping, we need to have the patient quite still, because otherwise it's quite impossible to perform that sort of punctures. You can even have your blockage, the nerve blockage, which is quite now popular, but I don't perform them.
Okay, and
we try to learn.
But my question is, so do you do all the procedures on the general, or do you do also something? It depends, you know, do you have patients that fit? Because probably in UK you don't have patients that fit to make anesthesia that dedicated. No,
definitely the complex ones, yes, on the general. Most of them are just local and some sedation, yeah.
Okay. Do you sedation? Because I mean, for me, like the sedation is the worst, because if it's not deep, then the patient
you're right.
And so I prefer to
they become crazy. Yeah. Yeah, you're right. You're right. Sometimes you.
I don't know. Like my professor, when I was in Italy, was saying 2 good sentences to convince the patient to stay still and to fight together. I think also, do you agree that the patient involvement in your procedure is important? So to motivate the patient to fight, you know, I think it makes a difference. Do you agree?
Yeah. Nerve block is probably a good idea, but I need to learn about that. We need to visit Stephen Kuhn.
Okay. There's a very nice website actually. Now I will maybe try to give you the address. It's very nice because it's important to learn how to do it, and it's mainly mastered by the anesthetist. So the website is nisora.com, nisora.com. So for everyone who's online, I think it's a very nice website where it explores every single nerve block. And actually, what I learned is the popliteal block, where you just go around the fascia of the nerve at the level of the popliteal fossa. You puncture, let's say, 2 centimeters above from the ligament, and you go into the nerve. This has to be done under ultrasound, not under fluoroscopic guidance. And you inject in the fascia, and actually in 20 minutes, the whole leg is numb. And it's nice to do it before, when you consent the patient, and as soon as you consent, you stick the needle inside the nerve, and you have this good effect. I think, you know, we spent a lot of time with you, and it was very nice to have you here. And I really liked your wiseness, also your wisdom, because it was very important for me to produce an episode which was not just an enthusiastic of course, you know, rush of cases, and I think you did extremely well. It will help all the young people who starts dealing with all this stuff. And I think if you want to leave a last message to someone who needs to start, what would you say? Last minute, just give us a highlight.
Well, no, I would say that this is nice, this is fancy, this is elegant, but be cautious. But definitely you need to master these techniques, because otherwise your success rate for BDA cases will be really low, and more than 20% of the cases that cannot be performed with all of these extreme bailout maneuvers.
And also, last thing, how much is important to have a team around you who believes in what you do and supports you, because sooner or later some disaster will come. Am I right?
Yeah, definitely. This is teamwork.
Okay, good. So that's the last thing. So create a team around you of people supporting your practice and developing together, instead of being lonely rangers, because the lonely rangers don't go anywhere. So it's very important. So thanks again to August Isa, who stayed with us today for the 15th episode of Vascupedia Views. Vascupedia Views are going to close soon, so there will be other 2 episodes, and then August will be for everyone to have a nice period of leaves. And after that, we're going to start with more projects about aorta, about SFA, PPTL, and we will be happy to continue with this online education until, you know, we think that is going to be feasible and helpful for every one of you. I want to thank again our speaker today, which was like extremely helpful again, and see you next Tuesday, always on Vascupedia Views, always on Vascupedia Live app. 5:30 Central European Time, and be smart and wise as August when you come back home.
Enjoy your holidays.
Have a lovely
Okay, see you.
See you.